Hey everyone, in today's video, we're going to be looking at the eyes, ears, nose, and throat section of the PANCE blueprint, and we're going to be doing a high yield review of all of the topics, so stay tuned. Hey, Dr. G here, and today we're going to be going through the eyes, ears, nose, and throat Rosh review guide, which is going to take us through a high yield look and a journey through all of the different topics that are on our PANCE blueprint. Rather than take you through each topic individually, I want to go through this quick high yield guide so that we can kind of cover it all in one sitting. Now, this is not going to be completely comprehensive, so if you haven't gone back and watched my series of videos on the EENT system, I would recommend doing that first and then using this kind of right before your test to kind of brush up on the more high yield points. So let's dive into this guide. All right, so we see chapter 4, eyes, ears, nose, and throat. This is from the Rosh review. And here are the different disorders that we're going to cover. We're going to start with the eyes, then we're going to move to the ears, the nose, sinus, and then we'll end up with the oropharyngeal disorders. So eyes is probably half of the PANCE blueprint, and we're going to start with the most superficial stuff. We have conjunctival disorders, and first off is bacterial conjunctivitis. Now, we need to be able to differentiate between bacterial conjunctivitis, viral conjunctivitis, and allergic conjunctivitis. Bacterial is most commonly caused by Staph aureus. However, it can be caused by other things like strep pneumo and H flu. We can see Pseudomonas type in contact lens wear, so that's really important. The presentation is going to be a red or pink eye, usually just one eye, and it's going to be with purulent discharge, usually worse in the morning. So they'll usually have their eye kind of crusted or matted shut in the mornings. As far as diagnosis, we do a physical exam. It's a clinical diagnosis. We'll see that purulent yellow discharge with crusting, and then we will manage it with ophthalmologic antibiotic eye drops. So these will be topical antibiotic eye drops, usually like an erythromycin drop or a polytrim. But if we suspect that it could be Pseudomonas, like in a contact lens wear, we'll want to use something like a fluoroquinolone, like moxifloxacin. All right. Moving on to allergic conjunctivitis. So allergic conjunctivitis is going to have a little different presentation. So we're still going to see the pink eye, but it's going to be both eyes most often. And it's going to have the highlight symptom of itching. We'll also see some clear tearing. Won't be really purulent discharge, more itching and tearing of clear watery discharge. As far as the physical exam, we'll look at the eye. Sometimes we'll even see what's called chemosis, where the conjunctiva and the sclera kind of swell up a little bit. We might notice on other parts of the body different signs or manifestations of allergies like cobblestone mucosa at the back of the throat. And on here, it's saying we could have some cobblestone mucosa on the inside of the eyelids. That's usually for vernal keratoconjunctivitis, which is a specific type of allergic conjunctivitis in young male patients, most often. As far as management for allergics, we're going to think allergy type medications. Usually things like H1 blockers, like olpatadine drops are the first line treatment, but we also want to consider whether or not this patient has other allergic manifestations. We might need to give them a generalized allergy medication, like an oral antihistamine. Okay. We can also do some basic, kind of more supportive care things like cool compresses, artificial tears, and NSAIDs. Okay. Last up is viral conjunctivitis. So we've already seen bacterial and allergic. Viral conjunctivitis is most commonly caused by adenovirus, and the presentation is usually bilateral, red or pink eye. Sometimes it'll actually start in one eye and will kind of self-inoculate into the other eye. And on physical exam, we'll see the bilateral red eyes. We'll see sometimes some pre-auricular lymphadenopathy and copious watery discharge with a little bit of mucus, not as much as bacterial. And management for this is going to be supportive care, including cool compresses, artificial tears, and sometimes we can consider giving some antihistamines for itching or redness. A couple other specialty conjunctivitises is chlamydial conjunctivitis. So with chlamydial conjunctivitis, it's most commonly caused by Chlamydia trachomatis, and we see it most often in patients like neonates, anywhere from 5 to 14 days after delivery, which is later than what we would see with gonorrheal conjunctivitis in a neonate. As far as physical exam, we'll see a mucopurulent ocular discharge with some eyelid swelling and erythematous conjunctiva. We'll get a culture to help make the diagnosis, and we'll give oral erythromycin. Here's a really nice comparison for neonatal conjunctivitis between the gonorrhea flavor and the chlamydia flavor. So with gonorrhea, we'll tend to see it earlier, between 0 to 5 days, tends to be more extensive. We'll have some corneal involvement, and we can actually have corneal rupture. Chlamydia, we see it a little later after they're born, between 5 days to 5 weeks. Inflammation might be a little more minimal, and corneal involvement's rare, but these patients can also get things like pneumonia. And here's another little spectrum of where these types of infections fall on the kind of the timeline. Here's another really nice at a glance chart to compare some of the different pink eyes or problems with red eyes. This is the bacterial conjunctivitis we've already talked about. Now, iritis is an inflammation or infection of the deeper structures of the eye, so the iris. And they'll often get not only this pink red eye, but they will get blurred vision. They'll also have pain in the eye, which is different than pink eye, because plain old pink eye should not have pain, more discomfort. They'll also have some difficulty with photophobia. They usually don't have nearly the same discharge like a bacterial conjunctivitis would have. And the injection or the redness of the eye actually is in the perilimbic area. So right around where the cornea or the iris starts. We'll also see a clear cornea, constricted pupil sometimes, because when it dilates, it causes more pain with the inflammation, and we might see a normal intraocular pressure. As far as keratitis is an inflammation of the structures of the cornea. We'll often see blurred vision. It causes severe pain, especially with constriction of the eye, and they'll also have some photosensitivity or photophobia. They will also get the perilimbic. As you can see, the redness kind of kisses the cornea, and they might even have a clear to a cloudy cornea. Pressure and pupil size are normal. Last but not least, we have acute angle closure glaucoma, which I think we'll cover a little bit later. But they're going to have marked blurred vision and severe pain to the point where they have a headache, nausea, and vomiting associated with it. They'll also have some photophobia, and they'll have no discharge. The injection of the eye will be diffuse. They might have a cloudy cornea and a dilated or mid-sized pupil that's fixed. It doesn't react very well to light, and their eye pressures are going to be markedly elevated, above 40 usually. All right, moving on to corneal disorders. So cataracts. Cataracts, we usually see it, we can see it in one or both eyes, but we usually see it in the older patients. That's why they're typically called senile cataracts. And at some point in almost everyone's life, we'll have a little bit of cataract as the eyes age, and the lens becomes a little more opacified. The progression is really slow, and they get slow vision loss over months to years. It's painless vision loss, and they'll usually describe it as like a blurriness, with halos around the lights and trouble with night vision and night driving. Okay. They'll also get clouding of the lens on physical exam, so you won't be able to see through it as easily. And the treatment is surgical management. So we got to remove the cataract and replace it with an artificial lens. A corneal ulcer. So we most commonly see this in with staff, and most often in vignettes, I see contact lens wearers with pseudomonas. And this is kind of along the spectrum of keratitis. So a patient will have a history of trauma or extended contact lens use. This means they're wearing it during the day, at night, all hours of the day and night, and for once at a time. On physical exam, they'll have an ulceration with ragged edges, and they'll have severe conjunctival inflammation. They might even have some photosensitivity. We'll use a fluorescein stain with either a Woods lamp or a slit lamp to look for the ulcer and identify the margins of the ulcer. And then management is going to be an emergent ophthalmology consult, and they will decide what kind of medications to place the patient on. Usually a combination, if it's a bacterial infection, of antibiotic drops, and sometimes after the initial few days, they'll put them on steroid drops to assist with healing. So there's a different flavor of keratitis that we don't usually see, but it's pretty high yield because you either know it or you don't. So this is called ultraviolet keratitis, and it's usually seen in skiers that don't wear protective eye gear or welders. And the presentation is going to be bilateral decreased visual acuity and pain and redness. And on physical exam, we'll see fluorescein staining, but it'll show this very specific multiple punctate lesion. So you can see on here is lots of little uptake in little dots all over the cornea. So that's very classic of ultraviolet keratitis. Management, we're going to use topical NSAIDs and oral pain medication with or without antibiotics and cycloplegics. So we will want them to see an eye doctor as well, just to make sure things heal up appropriately. Next up, herpes simplex keratitis. So this is usually a unilateral eye pain and redness, plus or minus some blurry vision and photophobia. They also have this foreign body sensation and some watery discharge. On physical exam, you'll see conjunctival injection near the corneal limbus, so it's also called a ciliary flush. And on diagnosis, we'll want to use a fluorescein stain with either a slit lamp or a Woods lamp. And we're looking for those classic dendritic lesions, which look like little neurons or lightning bolts. And we'll notice these on the cornea. This is a sign that we do have a herpes simplex keratitis. And we'll want to treat them with topical and oral antiviral medications. They'll need a referral to ophthalmology so that they can have this followed, because it can be sight impairing. There is some more specific findings differentiating herpes keratitis from zoster ophthalmicus. This is not something that I would routinely see tested. Just know that they can both cause similar presentations, but zoster is usually in that V1 distribution of the trigeminal nerve. You'll see Hutchinson sign on the nose. We want to look in the eye. For herpes, we may or may not see the actual herpetic vesicles, and this is usually in a younger patient. All right, next up is pterygium and pinguecula. I don't know why, but testing world loves to compare and contrast these two. I think they're pretty easy to differentiate. So pterygium is going to be a history of excessive sunlight exposure or wind exposure, working out in the heat along the equator in a dry, hot climate. Patients often just have a foreign body sensation, or they'll be completely asymptomatic. We'll see on exam this triangular shaped growth that does not respect the cornea, so it crosses over and can cross over into the field of vision. It's usually on the nasal aspect of the eye. And for this, initially, conservative management will be just some artificial tears and protecting the eyes against the sun and the wind and the dry heat and air. And if it starts encroaching on the vision or it becomes a cosmetic issue, we can refer for surgery. In contrast, we have a pinguecula, which is this little fleshy or yellowish colored mass, usually also seen on the conjunctiva, but this does not cross over onto the cornea, so it respects the cornea, and it's usually on the lateral side rather than the medial side. And it's yellowish raised, and it usually doesn't cause any issues. All right, next up are the lacrimal disorders. So we have dacryocystitis and dacryoadenitis, another good compare and contraster. So dacryocystitis is infectious obstruction of the nasal lacrimal duct, which is going to be on the nasal aspect. So the duct is what's carrying our tears and emptying them into the nose. It's usually going to be unilateral. We see it really often in kiddos. There have erythema, swelling, warmth, and tenderness. Sometimes you can push on that duct and actually express some purulent drainage. And because it's drained and blocked, they'll actually get what's called epiphoria, which is where the tears kind of overflow. Some complications, they can actually progress to getting that preseptal cellulitis or even orbital cellulitis. And they can also get meningitis from this, from cavernous sinus spread. And then treatment, we treat with flora that treats kind of staph and strep, including clindamycin, or if it's severe, we can do a vancomycin or a third generation cephalosporin. Dacryoadenitis is going to affect the gland, not the duct. So the gland is located here on the temporal aspect, the upper outer lid. And here we'll see the same thing, kind of inflammation of the gland in the supratemporal region. It usually happens pretty quickly. They get pain and redness and pressure, and we're going to want to treat that as well with antibiotics. All right, now some lid disorders. So blepharitis. Blepharitis is most commonly caused by dysfunctional meibomian glands. They get kind of clogged, and it can be infectious in nature. It can be from like excess sebum production. It can be from a lot of different things, but we see staph as one of the major culprits. We have some eyelid changes. We get flaking, dryness, and seborrhea sometimes. Diagnostic, we're going to want to look with the slit lamp, make sure there's no mites, kind of look at those ducts. And management's going to be warm compresses with lid massage, and we'll want to use topical antibiotics for flare-ups. And then it's commonly associated with seborrhea or rosacea. Be sure when we look at vignettes for blepharitis, they're going to mention things about the eyelid margins being red, inflamed, and they'll often mention that the eye itself or the conjunctiva is not red and not inflamed, just to help you differentiate it from like pink eye, although you can get some red eyes with blepharitis. A hordeolum, commonly known as a stye, this is a red, painful lump near the eyelid margin. It can be internal versus external, and they're both treated similarly. It's usually caused by staph or bacterial infection. We want to start with conservative management, including warm compresses and gentle massage, and then we can progress up to topical antibiotics if it's not improving. In contrast, another compare and contrast here, contrast is a chalazion. So a chalazion is most commonly caused by obstruction of the meibomian gland, and the presentation is a painless mass, usually on the upper eyelid, but it can be on either or. Management for this is again going to be conservative with warm compresses. If there's progression to blepharitis or cellulitis, we can include topical antibiotics. But if it's not going away after warm compresses and kind of time, letting things kind of sit, then we can refer them for drainage with the ophthalmologist. And here's a nice little chart kind of comparing the two. Major thing, painful, infected, not painful, not infected. That's the major difference there. Now for the ectropion versus intropion, another compare and contrast. And we just love this in the eye, right? So an ectropion is when the eyelid droops outward. So you can see a picture of that here. It's usually caused by aging and the general aging process where things lose elasticity, including our eyelids. These patients have excessive tearing because of dry eyes. Because they can't completely close or blink their eye to help flush the tears over their eye. And on physical exam, you might see a red eye and the eyelid will be turned outward. The treatment is going to be supportive care initially, and then definitive treatment will be surgical repair. For an entropion, we're also going to see patients that have problems with the elasticity of their eyelid, but on this case, the eyelid's going to be turned inside. So we're going to see a foreign body sensation because you got those eyelashes kind of rubbing on there. You'll have tearing and red eye. And the definitive treatment for this is going to be surgery as well. Although if it's not too bad early on, we can do some supportive care, including Botox. Okay. Next up, neuro-ophthalmologic disorders. So nystagmus. Nystagmus is more of an indicator, a symptom, or a finding that we see on physical exam. Main things you want to know for like exam purposes is going to be if it has a down or an upbeat, so it's more vertical in nature. It's usually more of a CNS issue. So think things that you saw in like your neuro module. As far as vestibular, you'll usually see a horizontal nystagmus with a vestibular cause or a peripheral vertigo type cause like labyrinth or vestibular nerve dysfunction. And if it's gaze evoked, this is most common and it's often benign. Optic neuritis. So optic neuritis is most commonly associated with multiple sclerosis. Remember, we see it in young females most often, and it's usually the first indicator of multiple sclerosis. So we'll have an acute presentation of monocular, so one eye, painful vision loss, and they usually have loss of color vision and most notably loss of red color vision. It'll be a transient worsening of vision with increased body temperature, which is also called the Ufthoff's phenomenon. I didn't even know that. And as far as diagnostic studies, the diagnosis is going to be made clinically. We also want to get an MRI to confirm that there is some demyelination that's associated with that multiple sclerosis. They also might have what's called a Marcus gun pupil. If you don't know what that is, look it up. And they'll have the treatment for this will be IV steroids, and we'll also do the neural workup. Next up is papilledema. So this is most commonly secondary to increased intracranial pressure. So think those things back from the neural module that cause increased intracranial pressure. So how do patients typically present with papilledema? Well, they'll have this acute onset of intermittent headaches, blurred vision. It's usually positional. So when they bend over, it gets worse. They'll also have it kind of worse the first thing in the morning. And basically when we look at the back of their eye, we'll see optic disc swelling, and that is consistent with papilledema. And we need to treat the underlying disorder. Okay. And we want to focus on figuring out what the intracranial pathology actually is. Orbital disorders. So orbital cellulitis versus periorbital cellulitis, another compare and contrast. We just love this pattern recognition in EENT. So for orbital cellulitis, this is the lights and sirens. This is the worst off presentation. We'll get swelling around the eye and even behind the eye. This is painful. They'll have pain with limited extraocular movement, and they'll have sometimes proptosis, which is bulging of the eyeball. It's usually just one eye. The diagnosis is made clinically, although we do get CTs most often to kind of assess for how bad the infection is and whether or not there's abscess formation behind the eye. Management is going to be urgent ophthalmology evaluation. We're going to start broad spectrum antibiotics. Compare this to preorbital or preseptal cellulitis, which is generally just more of a cellulitis or an infection of the anterior skin around the eye. It's less worrisome. Extraocular movements will be intact and not painful, and they won't have that proptosis. We often see this more in children than adults. It can be extravasation from a bacterial rhinosinusitis, and we want to start again the broad spectrum antibiotics, including Vanc and Zosyn. And we can consider surgery if we have like a large abscess back there. It needs to be drained. So you need to know the difference between preseptal cellulitis and orbital cellulitis. For preseptal cellulitis, a lot of times we can send the patient home if it's not too bad on oral antibiotics. Okay. All right, retinal disorders. So macular degeneration, we're going to see this. It's usually called age-related macular degeneration because we see it often in older folks. And it's usually bilateral, gradual, and we get that central scotoma or central vision loss. We'll also see the wavy lines, right? So when they look at something that's straight, like an Amsler grid or the blinds, they'll see them as wavy. And this is another early indicator of macular degeneration. We got two types of macular degeneration. We got the dry type and the wet type. So with dry macular degeneration, which is by far most common, we're going to get atrophic changes and yellow retinal spots, which are called drusen. With wet macular degeneration, we're going to also see this, but plus vascular changes at the back of the eye. Diagnostic studies, well, we want to use an Amsler grid to help a patient monitor the progression. And we also, it's one of the most common causes of blindness in the elderly. Here's some differences between the dry and the wet. Wet is definitely worse off than the dry. And we treat with lots of antioxidants and things like that, protecting the eye with protective sunwear and just kind of monitoring the progress. Retinal detachment. So retinal detachment is usually one eye and it's painless, a loss of vision, usually like a curtain lowering over the superior temporal region of the eye. We'll also see floaters and flashing lights, and it's more common in patients that have severe myopia or bad nearsightedness or recent trauma. The retina might appear a little bit hazy with white folds. If we look at the back, we'll see that detachment, usually a little tear associated. It is an emergency, so we want to get an emergent ophthalmology consult. Until then, we want to have the patient turn towards the side of the retinal detachment. Right? And just for the record, regimentaginous is the most common type of retinal detachment. All right, diabetic retinopathy. So patients can have a history of diabetes, usually uncontrolled. It will get progressive central vision loss, seeing red spots or floaters. And the most important thing for this is going to be the findings on the fundus, so the back of the eye, which we need to have examined at least once a year for screening purposes. So we'll see these microaneurysms, hypervascularization, hemorrhages, and cotton wool spots. This is all due to increased floating around sugars in the eyes. They tend to damage blood vessels. And when that happens, the body thinks, oh, well, I'll fix it by adding more blood vessels, which are like little baby blood vessels. You get neovascularization, and you get like leaky blood vessels in the back of the eye. And that is considered the proliferative type, and that's the bad type. This is sight impairing. We want to, for management, keep their glucose in check and have the routine screening exams to help catch it early so we can do these things like laser surgery or vitrectomies. So here's the difference between the non-proliferative and the proliferative. You'll want to know the findings like the hard exudates, the microaneurysms, occluded vessels, cotton wool spots. You'll want to know those findings. I highly, highly doubt that they would just give you a fundus and have you read that look at the back of the eye and know exactly what it is without kind of giving you these hints and these hard exudates, these cotton wool spots and things like that, without telling you that's what they are. But you should be familiar with the different changes at the back of the retina and know the difference between the two. Retinoblastoma. So retinoblastoma is the most common cause or the most common intraocular cancer in kiddos. It's most commonly caused by the loss of function of the retinoblastoma gene, which is RB1. And the most common physical exam finding is going to be that leukocoria in one eye or a white pupil, right pupillary reflex. And again, it's the most common intraocular tumor in kiddos. Usually see it in less than 2 years of age. So it's going to be like a toddler or a baby that we see it. And a lot of times parents will find this incidentally when they take a picture with a flash. They'll see a normal red reflex and then they'll see the white reflex, which is classic for retinoblastoma. And there's varying degrees of treatment that we will do for it, all the way from removing parts of the tumor to removing the whole eyeball. We want to look for an increased risk of osteosarcoma concomitantly. All right, traumatic disorders. So, blowout fracture of the orbit. So, we know that the bony orbit around the outside is pretty strong, but the orbit itself is actually pretty thin bone. And the weakest part is the inferior wall, which overlies the maxillary sinus. We'll have a history of direct trauma, like a ball to the face, a punch to the face. And the problem here is that once that bone breaks, the inferior rectus muscle tends to get entrapped in the bony fragments, and the patients have limited upward gaze, which causes diplopia when they try to look upward or double vision. And they might have some damage to the infraorbital nerve, or they'll get some anesthesia or numbness in that area. They might also have endophthalmos, where the eye kind of looks a little sunken in. The diagnostic test of choice is going to be a CT, which will show the teardrop or the falling of the contents of the eye into the maxillary sinus. And treatment is usually surgical. So we need to consult ENT or ophthalmology or plastics, whoever's on call, and have them take a look at the patient. All right, corneal abrasion. So we'll have a history of recent trauma to the eye, either a scratch or contact lens use, or a baby that scratches their eye, fussy, and we'll have pain, foreign body sensation, tearing, photophobia. The diagnostic test of choice is going to be using a fluorescein stain, either with a slit lamp or a Woods lamp, and we'll see uptake of the stain in the area that is scraped. You can think of it as like a scrape on your eyeball. Okay. We want to remove foreign bodies. If there are foreign bodies present, we'll want to flip the eyelid, make sure there's nothing stuck up and under there. And if they have contact lenses and that's the reason why they have this abrasion, we need to cover for anti-pseudomonal coverage. Excuse me. If we have a zigzag pattern, meaning or a constant kind of up and down pattern of the abrasion, we're going to look for that retained foreign body underneath the lid, because every time we blink, it might be kind of re-scratching the eye. And we don't want to prescribe the topical anesthetics that we might use during the staining process, like proparacaine, because long-term use can result in a corneal ulcer because they won't be able to feel it when it hurts. So make sure that you take those drops out of the room after you're done using them. We'll prescribe topical antibiotics usually to help heal this up without infection, and they'll need to follow up with ophthalmology, especially if the abrasion is in the line of sight. Okay. And we need to update their tetanus if they're not up to date. A globe rupture. So this is usually pretty striking when we see it. We'll have a recent, history of trauma or penetrating injury to the eye. One of the classic things we'll see on exam is this teardrop pupil, and it's usually the angle is towards the area of perforation or of rupture, and you might not always see the teardrop pupil, but in most of the time in vignette world, they will tell you something about a teardrop pupil. I kind of think of it as like when you break a window in an airplane and you get that change of pressure, it kind of sucks things out. So it sucks part of kind of that iris or the pupil kind of out that way. Well, also, if it's a very mild globe rupture, we might not see any changes, but when we do a fluorescein staining, we'll see what's called Seidel's sign, which is when we see the aqueous humor kind of gently leaking out and creating streaks. That is also an indicator of a globe rupture. What do we do when we have a globe rupture? Well, we might need to get a CT of the orbit to help us establish the diagnosis, and we'll need an emergent ophthalmology consult. We'll want to elevate the head of the bed, start them on antibiotics, and protect the eye with a rigid shield on the eye. We don't want to do anything. Don't look, don't touch, don't make eye contact with these patients. I'm just kidding. But we don't want to touch it. We don't want to put anything in it if we know that we have a globe rupture. And so we'll do these things: elevate the head of the bed, keep them NPO because they might need to do surgery, give them some pain medication, and get ophthalmology on board ASAP. Hyphema. Hyphema is blood in the anterior chamber. There are 4 grades of a hyphema, and it has to do with how full or how much blood is within the anterior chamber. You usually have a history of blunt or penetrating eye trauma, and the patients will present with blurry vision. Be careful because in dark iris patients like brown eyes, it might be hard to see a small hyphema. So you want to take a really good look and use tangential lighting to see it better. We might also have a history of unequal pupils, injective conjunctiva, and the management is really protecting the eye, getting ophthalmology on board. So we want to keep the patient's head of the bed at 30 degrees to keep the blood kind of in the anterior chamber. Also, something associated with a hyphema, if we see it recurrent, or we might also need to think about, maybe just think about sickle cell. Let's see. We want to avoid antiplatelets, anticoagulants, and avoid carbonic anhydrase inhibitors in sickle cell patients and get the ophthalmology consult. Vascular disorders, so this is occlusion of the vessels that are going to the eye. We have CRAO and CRVO. So central retinal artery occlusion is going to be a sudden painless monocular vision loss. It's kind of like a TIA of the eye or amaurosis fuga that does not transient. So that stays there usually more than an hour. And they will have almost complete vision loss, or they'll just have light perception depending on how big the clot is that goes to the eye. On fundoscopy, we'll see the classic presentation of a cherry red spot, which is the macula at the center of the vision. It gets a little bit of its blood supply from another place, so it looks a little more blood rich, and around it's going to be pale because we're not getting good blood flow to that area due to the occlusion. Well, I might also see some boxcar appearance, which look like little train cars where there's little micro occlusions of the vessels in the back of the eye. Treatment is going to be globe massage, and we want to lower intraocular pressure and get ophthalmology on board. A lot of times they lose their sight no matter what we do, but we try our best to intervene as best as we can. In contrast, if you think of this as kind of an eye stroke, you can think of CRVO as kind of an eye DVT. So it presents kind of similarly, usually a little less sudden, and they'll often have a history of hypertension, diabetes, or a coagulation disorder. Presentation might have different degrees of sudden painless monocular vision loss, but the major difference between the two is going to be what we see in the back of the eye. Because this is a blockage of blood flow from the eye, we get vessels that kind of burst the back of the eye. So we'll see this classic blood and thunder appearance on fundoscopy. We'll also see tortuous and dilated veins within there because they're full of blood because it can't drain from the eye. And this again will be an emergent ophthalmology consult. And these guys can get some of the antivascular endothelial growth factors, so we can try to limit the bleeding that happens in the back of the eye. All right. Here's that amaurosis fuga we referenced a few seconds ago. That's going to be our fleeting darkness. So this is most commonly caused by a carotid embolus. So from plaque in the carotids, they go up. The first line, or the path of least resistance, is going to be to that central retinal artery and the ophthalmic artery. And we're going to have transient monocular vision loss. Transient, usually a few minutes to seconds, not usually longer than that. If it's longer than that, it's encroaching on more than an hour, so it's not transient anymore, and that is a central retinal artery occlusion. And they'll often describe it similarly as a curtain coming down over their vision. And that's amaurosis fuga. We also have to do a stroke workup on these and the CRAO as well, because a lot of times the second clot that throws is worse than the first. So glaucoma is an umbrella term that means increased intraocular pressure. And this can be caused by several different things. We basically have 2 main types. We have the open angle glaucoma and the closed angle glaucoma. So open angle glaucoma is actually more common, and it's less sudden and less kind of lights and sirens, right? So it's caused by the slow blockage of the drainage canals. The angle itself is open, and it develops slowly over a long period of time. And a lot of times, patients are asymptomatic until later in the process. So we actually screen for this starting at the age of 40. As you can see here, it's probably a good thing that 90% of cases are open angle because they tend to be less acute. As far as closed angle is lights and sirens. This is a sudden blockage of the angle of the of the anterior chamber. It results in a sudden rise in intraocular pressure, and it develops rapidly. The symptoms and damage are very noticeable, and it requires immediate medical attention. So here's another quick look. A lot of times we'll see a patient that walks into a dark room like a closet or a movie theater. That dilates the eye and kind of stacks the iris in the corners, kind of further blocking off an already closed angle. And that's kind of how that precipitates the acute angle closure glaucoma. They'll present with halos and acute unilateral painful vision loss. Sometimes they'll have vomiting as well. On physical exam, and this is one of the only ones that I've seen that really causes that headache and the vomiting that's associated with the eye. Sometimes it can even be confused for like a migraine with aura because it can be so bad. On physical exam, we often see a cloudy cornea, and this is very classic, a fixed mid-dilated pupil. We'll also want to use tonometry, a tonometry pen, to check for increased intraocular pressure. And it says here that it'll be greater than 21 millimeters of mercury, but often it's up way above, like greater than 30. Okay. And as far as treatment, we want to initiate multiple different treatments to try to lower that intraocular pressure. So we'll start topical beta blockers, carbonic anhydrase inhibitors, steroids, miotics to constrict the eye so that we kind of open up that angle a little bit more. And here's some of the other treatments that we'll do. We'll do the IV acetazolamide, mannitol to help reduce the pressure, and then these to also try to constrict the eye so that we have opening of the angle. And we need an urgent or emergent ophthalmology consult. And this is in contrast to the open angle glaucoma. So with open angle glaucoma, we want to screen for it. We're going to look at the cup to disc ratio. We're also going to look at peripheral fields, change in the vision, the peripheral field vision, and we're also going to test the pressures in the eye. But this is on more of a chronic basis, and they can be placed on medication to help lower the pressures long term. All right, strabismus. So strabismus is a wandering eye, right? So any form of ocular misalignment when the two eyes are not looking in unison, that is considered a strabismus. So we have different types. We have exotropia, which is the outturning of the eyes, esotropia, which is inturning of the eyes. We want to use what's called the cover-uncover test. That's going to basically force the bad eye to kind of go back into position. If we see that happen, it kind of confirms our diagnosis. There's a bunch of different types of this. Basically, which way is the bad eye turned at rest? And we have to treat this by patching exercises. So we want to cover the good eye, and that will force the bad eye to kind of do its thing and kind of strengthen up. And we want to treat it before especially when it's in kiddos, before the age of 2 to help reduce the development or the turning into amblyopia, which I think we'll cover a little bit later. No, we won't. We're going on to ear disorders. So the difference between amblyopia and strabismus is just kind of an anatomical defect. The two eyes are not tracking together. Amblyopia is actually the body's way of turning off a bad signal. So if my right eye is not lining up and I'm not getting good input or feedback from that eye, my brain eventually, if it's not corrected, is going to turn that eye off and basically cut off the cortical tract to the brain. And so amblyopia happens over a period of time, and we want to try to prevent that by addressing the problem. All right, that took us a while. That was like 40 minutes of just the eye, but I guess it beats like hearing the whole thing. So I'm trying to go as fast as I can, but there's just a lot of information, a lot of different diseases to cover. So ear disorders. We have the external ear. First, we're going to talk about cerumen impaction. So it's the most common cause of conductive hearing loss. We need to know our Weber and Rene tests to differentiate conductive and sensorineural hearing loss. We're going to see cerumen in the external canal. They'll have ear fullness or hearing loss, itchiness, and we'll use cerumenolytics like Debrox or things like mineral oil or peroxide, or we can remove it via irrigation or manual removal. Okay. Otitis externa, pain, we're going to see most commonly caused by Pseudomonas. We're going to see pain, a history of swimming or exposure to moisture. We're going to have discharge from the ear, some swelling, maybe some itching, and pain with movement of the pinna or pushing of the tragus. That's classic. We're going to use topical antimicrobials that cover Pseudomonas, like Ciprodex or acetic acid with hydrocortisone. As far as management, I mean, most often it's caused by Pseudomonas. Every now and then we might find a fungal etiology, but it's really rare. We need to differentiate regular otitis externa from malignant otitis externa, which is usually a complicated version of otitis externa seen in diabetic or immunocompromised patients. And whereas swimmer's ear basic otitis externa is treated with topical antimicrobials, this malignant otitis externa is treated with IV antibiotics and admission to the hospital. All right, here it is. This is necrotizing or malignant otitis externa. Think of it in elderly patients with diabetes or immunocompromised patients. They're going to have real severe pain. They might look toxic, have fever, and won't respond to topical treatment. And the pain tends to be worse at night. And we need to admit them to the hospital, give them IV antibiotics, and we can consider getting a CT to better evaluate the extension of the infection. An auricular hematoma is blood between the skin of the ear and the cartilage, which can be bad because it can lead to long-term scarring of the ear, hence cauliflower ears we see in wrestlers and other people. So usually caused by blunt trauma, kind of over and over and over again. And what we want to do if we see this acute setting is we want to evacuate the blood via um, aspiration or IND. And then we want to put a pressure dressing on it so it doesn't reaccumulate, and we can start them on antibiotics to prevent infection of the cartilage. If we don't do this, we might develop cauliflower ear. Inner ear. So an acoustic neuroma, or better known as a vestibular schwannoma, we probably covered it in our neuro module, but it's most commonly caused by cranial 8 tumor, which is vestibulocochlear nerve. The presentation is usually gradual sensorineural hearing loss, tinnitus, and balance disturbance, and plus or minus a facial paresis if we get encroachment on the facial nerve. The diagnosis of choice is going to be an MRI, and the treatment is going to be surgery. Barotitis is ear pain that persists after an event. So usually happens, it's kind of like barotrauma, right? So it happens when we're flying or we're scuba diving or something like that. And we get a sudden pop within the ear. It can kind of squeeze the eardrum and cause pain, and it can actually rupture the tympanic membrane. So keep an eye on that. There's the Toynbee maneuver or swallowing can kind of help with that. Labyrinthitis is a history. Usually we'll have a history of recent URI. You'll get continuous, persistent vertigo, and in labyrinthitis, you'll also have hearing loss. And this can last from several days to up to a week, and it can be very, very debilitating. If we have vestibular neuritis, it'll be all of the above without the hearing loss. So vestibular neuritis is vertigo, gait instability, nausea, and vomiting. If we have the hearing loss, it is considered labyrinthitis. So that's the difference between the two. Not much we can do. It's self-limited. We want to give the patient medication to try to suppress the vertigo and the dizziness and the nausea. And that's pretty much it. BPPV, the most common type of vertigo, peripheral vertigo that I see, most commonly associated with a displaced otolith. So they got a little stone within the semicircular canals that gets displaced, and it causes dizziness. Usually get small, short episodes of the room spinning, and it usually happens with changes in the position of the head, and it lasts from seconds to minutes. So very short episodes. Two things you need to remember: positive Dix-Hallpike maneuver. That's how we diagnose BPPV, and how we treat BPPV is via the Epley maneuver, which are both trying to, the Dix-Hallpike maneuver, we're trying to recreate that dizziness, and we'll look for a rotary nystagmus. And the Epley maneuver, we're trying to basically put that otolith back where it came from. We can also give them some treatment for nausea and for dizziness, symptomatic treatment as well. Here's the Dix-Hallpike maneuver. Make sure you know the difference between the Dix-Hallpike and the Epley and how they would be described in a vignette. All right. One other thing that kind of take a step back here is know the difference between central and peripheral vertigo. Maybe not so much for an EENT module test, but on the big picture on your PANCE exam, you're really going to have to know the difference. And so I think this chart will save for later, but basically we need to kind of compare our neuro-y stuff with our ENT stuff. Major things we're going to see is peripheral vertigo is usually more sudden, and it lasts shorter periods of time, so more seconds to minutes. And the intensity is really, really severe in peripheral. Whereas in central, we'll get a little bit less sudden, a little milder, and it won't be usually worsened by position. As far as the nystagmus, so usually the peripheral will be unidirectional and it's never vertical, whereas central can be any which way, but if it's vertical, it's always central. And they should not have any neurological findings on peripheral, but they might have some on central. And auditory stuff, we should see it in peripheral most often and none in central. And then here's some of the most common causes. Cholesteatoma, history of chronic ear infections or TM tubes. We're going to have painless otorrhea and a conductive hearing loss. And on exam, we look in there, we're going to see a pearly white or yellowish white mass behind or even eaten through the tympanic membrane. And the treatment is surgery. Acute otitis media, very, very common, most often viral. But if bacterial, we're going to see our common players like strep pneumo, H flu, and even Staph aureus. Patients, we're going to see them most often in young infants or in children. They'll have ear pain, fever, and usually recent URI symptoms because of the boogers and stuff kind of back up behind the tympanic membrane. When we look at the TM, it should be erythematous, and if we're in the textbook world, we'll have decreased mobility of the tympanic membrane with insufflation, so it won't move anymore. Treatment is going to be amoxicillin, a higher dose, 80 to 90 milligrams per kilogram. We also need to know the indications for treating with antibiotics because not all patients require treatment with antibiotics. And we also need to know who is needing of ear tubes. So we have 3 episodes in 6 months or 4 and 12 months. Those are the kind of kiddos that are going to need ear tubes. All right, and here's your treatment for acute otitis media. Tympanic membrane rupture. So we have a TM, it's less than a millimeter thick, very, very thin, and several things can burst our TM. So we'll often see in the setting of pain, otorrhea, hearing loss, or reduction. It can happen via infection, it can happen from loud noises or explosions or concerts or from direct trauma. Most of them are going to heal spontaneously, so we want to encourage keeping the ear canal and the TM clean and dry, and only treat with antibiotics if the cause of the rupture was from an infection. And we'll refer them to ENT for a recheck, and if it hasn't closed up in about 2 months, then they'll surgically repair the tympanic membrane. As far as hearing loss, you need to compare conductive and sensorineural. So conductive most commonly is going to be cerumen impaction, things caused by otitis media, serous otitis in younger kids. And on physical exam, we need to compare the Weber and Rene. So Weber is going to lateralize to the affected ear. Rene is going to be abnormal. So bone conduction is going to be greater than air conduction. Sensorineural hearing loss. If we have acute onset of sensorineural hearing loss, these need to be acutely referred to the ENT specialist because a lot of times we need to start them on steroids and do a quick analysis of why they are developing this sensorineural hearing loss to prevent it from becoming long term. It's most commonly associated with noise exposure, drugs, or aging, like presbycusis. So the Weber is going to lateralize to the unaffected ear, and then we're going to have a normal Rene, which is air conduction is going to be greater than bone conduction. Let's keep going. So here's the Weber Rene. You've got to know this. It's going to be on every test you ever take. Mastoiditis. So this is usually a worsening of acute otitis media. It's a complication of this. Whether or not we treat or not, usually untreated or poorly treated acute otitis media, we're going to have fever, ear pain, plus the erythema and maybe some bulging or swelling to behind the ear that's affected. And we'll often see kind of forward displacement of the external ear. This is admission to the hospital. They're going to get a CT to look for the extension of the infection, and they're going to get IV antibiotics. Okay, so this is worse. If you see the swelling, you need to admit them to the hospital. Okay, and some will do IV antibiotics, and sometimes they'll actually need surgical drainage. Meniere disease. So Meniere is a specialized type of vertigo or causes vertigo. It's most commonly caused by excessive inner ear pressure because they have too much endolift within these semicircular canals. Presentation, they're going to get episodic, usually a little longer than BPPV, so from minutes to hours. They'll have episodic episodes of vertigo, and they'll have low frequency hearing loss and ringing of the ears. They might also complain or report fullness, feeling full in the ears. And again, the vertigo will last between 1 to 8 hours. So it is still episodic. Diagnostic studies, really a clinical diagnosis, and the management's going to be a low sodium diet because we have too much endolymph and diuretics. Okay, here's our triad. So episodic vertigo, sensorineural hearing loss, low frequency, and tinnitus. Very good. All right, we finished the ears. That wasn't too bad. We did that in like 11 minutes. All right, we're making progress. Now let's go on to the nose. So the nose, epistaxis. So nosebleeds, very, very common. We need to know that there's anterior and posterior nosebleeds. The most common location of an anterior bleed is from Kisselbox plexus. And I think that the anterior is close to our lips, so we kiss it, right? So we kiss the anterior bleed. The most common location of posterior bleeding is from the sphenopalatine artery. Remember, anterior, not so bad, posterior, really bad. And anterior, way more common, posterior, not so common. Anterior bleed, we're going to try first direct pressure, and that's 10 to 15 minutes of continuous direct pressure on the nose. Once we do that, if it's still bleeding, we want to try to localize the vessel that's actually bleeding. If we can localize the vessel, then we're going to cauterize it with silver nitrate or with other cautery methods. If we cannot locate the actual vessel that's bleeding, we might try some sprays of Afrin or a pledget of Afrin. And if that still doesn't cut it, we'll probably put anterior packing up the nose. It's like a rhino rocket. And we usually leave that in for a period of time, have them follow up with ENT, and we'll need to place them on oral antibiotics. If it's a posterior bleed, none of this is going to work. It's going to be excessive bleeding, usually out the nose, down the back of the throat. We'll usually see it in older folks, people with hypertension or atherosclerotic disease, and it's way more severe. And we need to assess their ABCs first. Make sure they're not bleeding so much that they can't breathe or that they're not going to aspirate blood. We might need to intubate them. And then we need to place posterior packing and get ENT on board. All right, allergic rhinitis. So this is really, really common. We'll see it all the time in the clinic. They're going to have a history of other allergies, usually like asthma or atopic dermatitis or aspirin sensitivity. They'll have sneezing, rhinorrhea, nasal congestion, or runny nose, infraorbital edema. So we'll see some darkening underneath the eyes. Those are called allergic shiners. We might see a transverse nasal crease from the kiddos kind of doing this all the time. So we'll get a crease there. We might also see cobblestoning at the back of the throat from that postnasal drainage. As far as diagnostic studies, we might get an elevated serum IgE because it is IgE mediated. And we'll want to treat them. First line treatment for allergic rhinitis is going to be intranasal glucocorticoid spray. So steroid nasal spray is number one. Other things we can give are oral antihistamines and other things. All right, sinusitis. So it's most commonly viral, but if symptoms persist longer than 10 days, 10 is kind of the threshold, the pathogen is more likely to be bacterial. They'll often have pain over the sinuses, pain to percussion, pain with movement of the head, and they'll get purulent rhinorrhea plus that sinus tenderness. If it is viral, if it's less than 10 days, they don't have high fever, and they don't have any other findings that are suggestive like double sickening, then we can use supportive care like decongestants or steroid nasal sprays. If we suspect bacterial sinusitis because they've had it more than 10 days, they've had a double sickening, they have really high fever or facial pain, then we'll want to give them Augmentin first line if they're not allergic. All right, nasal foreign bodies, very, very common. Kids, if kids have holes, they're going to stick things in them. And one of the main ones that's easy to find is the nose. So they stick lots of things up there, most often beads and Legos and other things. Most often I see in vignettes, kids don't usually tell their parents that they do this because they're scared of getting in trouble. So we'll see this unilateral purulent nasal drainage, usually one side, and it's very foul smelling. So if we see that on a vignette, think a foreign body. We need to remove this because it is an aspiration risk, and there's lots of different methods we can employ. But most importantly, we need to remove it, especially if it's caustic like a button battery, or if it's a magnet that we have risk of swallowing or aspirating. All right, that was real fast. Nice. Next up, oropharyngeal disorders. So this is the last category here. We are almost done. I'm hoping we can get done in around an hour, which would be really great. So first off, diseases of the teeth and gums. Remember, we are not dentists, but we are the first line for most patients that have these problems. So we need to be familiar with how to diagnose them and how to get them on the right track to getting better. So gingivitis, we're going to see reddening of the gums, usually from poor brushing, poor hygiene, poor dental hygiene. And we want to encourage good dental hygiene, and they might need some antibiotics or need to see a dentist to get the teeth cleaned, and they might need to be cleaned under anesthesia. We'll see that brightly inflamed gingiva. And if it's just plain old gingivitis, we won't have mobility of the teeth, and we won't usually see a lot of erosion down here. But if it starts to encroach on what we call periodontal disease, that's when it starts to get worse. So we want to try to keep it from getting worse like that. This is actually called linear gingival erythema from HIV gingivitis, so it's a little worse off. Gingival hyperplasia, this is overgrowing of the gums. It's most commonly caused by medications like phenytoin, calcium channel blockers, and cyclosporine. And so we just want to ask about the medical history when we see something like this. Another one is Vincent's angina. It's also called trench mouth, which is really bad. Google it. It's necrotizing gingivitis. You'll see punched out lesions of the teeth. It'll look worse than just your plain old gingivitis. And it can be really, really bad. We'll see it more often in immunocompromised and smokers. They'll have foul breath, as you can imagine with this. They might have a metallic taste, and we'll give them antibiotics, chlorhexidine washes, and they'll need to see a dentist or oral surgeon. Dental abscess, usually caused by poor dentition, so they have little cavities or breaches in the tooth. Bacteria can get up and in there and cause little abscess. These abscesses are risk factors for other things like dental cellulitis. Facial cellulitis. And the treatment is IND of the abscess and placing the patient on antibiotics. And they need to follow up with dentists because it's basically treating the infection, but the infection is precipitated by a problem with the tooth itself, usually. Next up, aphthous ulcers, very, very common, otherwise known as canker sores. Lots of people get them because of stress or eating things with high acidity content. We'll usually see this circular lesion or ulceration within the wet buccal mucosa or on the tongue. And it'll be single or multiple shallow with a yellow-gray appearance in the middle with a red halo around the outside. If we have it for a longer period of time, more than a few weeks to months, or if we have a lot of them recurrent, we need to biopsy them. And we can give for management things like viscous lidocaine or magic mouthwash, which can kind of help with the pain. And we can also think of other more systemic diseases like Behçet's or maybe even inflammatory bowel disease if it's recurrent and it's not getting better. All right, oropharyngeal candidiasis or thrush. This is commonly caused by Candida albicans. Remember, Candida can cause diaper dermatitis. It can cause esophagitis. It can cause intertrigo underneath the skin folds. And in the mouth, it can cause what we call thrush. And it's going to present as creamy white plaques on the tongue and the palate and the inner cheeks, and it can be scraped off with a tongue depressor. And usually underneath, they'll have a little bit of redness or friability underneath it. And we use topical nystatin. Is most often used. It's a swish and swallow or swish and spit for adults. For kiddos, we might put some drops in the mouth and kind of paint it on with a cotton tip applicator. And we can also use clotrimazole troches or fluconazole, which is a pill that we can use. Retropharyngeal abscess. So this is an abscess in one of the deep spaces of the neck. There's several different spaces within the deep neck. It's most commonly caused by Staph aureus or group A strep, and as it travels from a plain old infection to these other spaces. We'll see it usually in kiddos and a toxic appearing kiddo, and usually between 3 and 5 years. And they might have a history of trauma or recent URI or throat infection. They'll have fever, sore throat, dysphagia. They might have trouble moving their neck or nuchal rigidity. They might not be able to open their mouth. They might have stridor or a muffled voice. And they usually just look really toxic and something just not right. And so you can start with a lateral neck x-ray. It'll show a widened area between the airway and the spine back here. So that's a widened retropharyngeal space. And a CT is going to be diagnostic. And we'll need to admit them to the hospital, protect their airway, give them IV antibiotics, and then they'll probably need surgery for an IND in the OR. And again, here are the different lines and spaces here. I don't know that you'd have to know the different spaces, but it is good to know that if you have a widened area up here by C2, then that can be indicative of a retropharyngeal abscess. Epiglottitis. We saw this in the poll module. We're seeing it again. here. So most commonly caused by strep and staph species. H flu was the most common cause prior to the HIV vaccine. We'll often see it in a vignette or in real life in an unvaccinated child. I've only ever seen it in an adult patient. They'll get rapid onset of fever, dysphagia, drooling, and stridor or dyspnea or trouble breathing. And they'll often be kind of leaning forward or tripoding. We'll get that classic lateral neck x-ray to show the thumbprint sign. However, if it's a kiddo, the most important thing is to do not agitate until we can intubate. So airway management is crucial, and we want to start the IV antibiotics that cover the most likely pathogens. Laryngitis. So laryngitis is an inflammation of the voice box. It's almost always viral or can be from overuse. Hoarseness is the major symptom. So having losing your voice completely or having a hoarse voice. Um, Most cases, since they're viral, they will heal on their own. They're self-limited. We'll want to hydrate, vocal rest, and maybe even some humidification. If it lasts more than 3 weeks, or if maybe they use their voice as their line of work, like a singer, we'll want to consider doing laryngoscopy. And that's to look for things like squamous cell carcinoma or other like lesions on the vocal cords that we would have to see. Peritonsillar abscess, very classic findings. Usually see it in adolescent, history of pharyngitis that gets worse. So we'll have severe sore throat, drooling fever. We'll get this trismus where they can't quite open their mouth very well. And we'll get a hot potato voice, which sounds like they have something hot in their mouth and they have a very muffled voice. And when we look at the back of the throat, the uvula will be displaced. We'll see the swelling in the peritonsillar region from the abscess itself. Management, we'll get a CT to see how big or how bad the abscess is. And then the management's going to be an incision and drainage or needle aspiration, followed by IV antibiotics. Okay. Pharyngitis. Pharyngitis is a blanket term. There are many different types of pharyngitis. Viral infection is going to be more common than bacterial, but the important one to know is bacterial infections is group A strep, or what we think of as strep throat, strep pyogenes. These are the most common pathogens. So presentation, we're going to have a sore throat, fever with anterior cervical lymphadenopathy and strep throat, with tonsillar exudates and no cough. We'll use the center criteria to help decide whether or not to do a rapid strep test or a culture. If it's viral, we'll use supportive care. If it's bacterial, we need to treat it because this will help us prevent those sequelae of rheumatic heart disease. It won't help us prevent post-strep glomerulonephritis because we can get this whether or not we treat it, but it is good to know that this can happen. Um, and usually we have these exudates back here. So if it is viral pharyngitis, just the typical type, usually it's like adenovirus that causes it, supportive care. If it's mononucleosis, I don't think we have a mono in here. Let's see, mumps, leukoplakia. No, there's no mono in here, but it's another really testable one. Mono is a special type of pharyngitis that usually we'll see in, they call it the kissing disease. Not just kissing, drinking after, or being in close contact with someone that has it. We'll see, again, red throat, sometimes exudates, and we'll see posterior cervical lymphadenopathy, and potentially we'll see splenomegaly. And if we have a patient that has mono, we can do a mono spot to test for it. And if it's positive and they have splenomegaly and they're a person that plays sports, we need to keep them out of contact, all sports really, but contact sports especially, for up to 4 weeks until the infection is better. So that's that. And don't give them antibiotics. Kiddos with, or anyone with mono, we don't give them antibiotics because if we do, we can actually get a rash from the Epstein-Barr virus. Salivary disorders. So sialadenitis is an infection of a gland, of a salivary gland, most commonly caused by staph. We get the mouth swelling and the pain is worse with meals because usually when the salivary glands have to start working is when we're starting to eat. So we'll do warm compresses, gland massage, sialagogues, which are like lemon drops or sour candies. And if it's acutely infected, we'll give antibiotics. Sometimes this can be precipitated by what we call sialolithiasis, which is stones that get obstruct the ductal system between the gland and where the saliva exits inside the mouth. One other thing to mention here is Keratitis, which is one of the salivary glands, the parotid gland, can be caused by mumps. Also, we see it in dehydration. We can see this in dehydration in the elderly population or in folks with Sjogren's syndrome that have generally dry dry glands. Mumps. So mumps is a viral infection caused by the paramoxioviridi virus, and we see it in unvaccinated kiddos. They get headache, vomiting, malaise, fever, prodded swelling, and tenderness, and they'll also have some leukopenia, lymphocytosis, and they might even have an elevated serum amylase, although that's non-specific. Most common complication in adults, they'll get orchitis, which is swelling of the testicular area, and it's self-limited viral syndrome, but we need to report it to the health department because it can be very contagious. And last but not least, oral leukoplakia. So oral leukoplakia is most commonly caused by precancerous hyperplasia of the squamous epithelium inside the mouth. So we'll see it a white plaque which cannot be scraped off, and we see it on either the buccal mucosa or the lateral aspect of the tongue. We'll see it most often in a man with a history of smokeless tobacco use or tobacco use. And if we see that and it doesn't scrape off, it's not candida, and we need to biopsy it to help to see whether or not it is truly precancerous, because anywhere from 5 to 20% of these types of lesions can actually turn into squamous cell carcinoma, which is bad. So we need to closely observe them. Surgical excision if we know that it is precancerous or cancerous. And it is not the same as oral hairy leukoplakia. Oral hairy leukoplakia is not precancerous. We see it, it's caused by Epstein-Barr virus. See it more often in HIV-infected patients, and it also can't be scraped off, but it looks a little more hairy, just like the name says. Whew. And we are done. So that was about an hour, a little over an hour of review of what Rosh Guide thinks are the most important topics from the PANCE blueprint. It's not everything, and there's no way I can go through everything in an hour that you need to know, but it's high yields, and high yield things are high yield for a reason. So I hope this was helpful. I hope this helped you kind of remind yourself what the most important things are about each of the disorders. As you can see, pun intended, the eyes are the biggest part of the ENT or the EENT blueprint. So spend a lot of time on the eyes. You're going to have a lot of questions on this when you get out in the field and on your PANCE or on your module exam. So thanks again for tuning in. I hope it wasn't too long-winded. I tried to go fast, but I hope this was helpful, and best of luck on any exam that you take here in the future.